Good morning, my name is Niccolò Perziani. I am a teacher of health management in the School of Medicine of Florence. May I introduce you to this training program organized by Centro di Salute Globale of Regione Toscana and UCOI, Unione Consoli Onorari Italiana. This program is focused on the first adoption guidelines and procedures to afford the coronavirus infection in a developing country. Okay, may I introduce you Maria José Caldes, the director of Centro di Salute Globale, who will present you the main topics of the program.
Good morning, my name is Maria José Caldes Pinilla. I am a public health doctor and currently I'm the director of the Global Health Center of Tuscany region in Florence, Italy. The Global Health Center covers all the aspects related to migrants' health and international health cooperation, coordinating all the regional actors in these fields. This project has been created with the cooperation of Dr. Chiara Maretti and was created with the aim of translating complex information about the COVID-19 epidemic in practical terms. In fact, in these days, we are inundated with a lot of information that comes from different media sources that sometimes are very difficult to decode. With the course and training lectures, we will try to give clear and practical advice tailored to primary healthcare needs in order to fill the knowledge gap that may affect the context. We hope that present course will be helpful to all health professionals in the containment of the current coronavirus outbreak. I really hope that you will enjoy the course. Thank you very much.
Thank you, Maria José. Now I introduce you Dr. Chiara Maretti, is a collaborator of Centro di Salute Globale, is an expert of WHO. She will tell us which are the guidelines that will be explained during the training programs. Chiara?
Thank you. Good morning. My name is Chiara Maretti, and my experience was developed in 2014 in Sierra Leone during Ebola outbreak and in 2019 in South Sudan during Ebola preparedness. I will now show you the program of our training course in detail. First, we will talk about preparedness, readiness, and standard measure of infection prevention and control. These are measures to apply to all patients regardless of their infection status. Therefore, in the second part of the course, we will discuss about additional measures to apply when caring for suspected or confirmed COVID-19 patients. Finally, we will go into details about COVID-19, its epidemiology, signs and symptoms, and a description of recent epidemic data and situation in Italy in early April. Thank you.
Thank Chiara. Now I introduce you Professor Bastianelli. Professor Bastianelli is the consul of Yemen Republic here in Florence and is the director of the study center of UCOI Honorary Consul in Italy.
Good morning. I'm Professor Bastianelli, surgeon otolaryngologist and also consul of Yemen Republic in Florence, and I have the privilege to be the director of the study center of the Union of Honorary Consuls in Italy. Our Minister of Foreign Affairs keeps the highest number of honorary consulate in Italy with more than 500 consulate, and also Italy has one of the highest number of honorary consulate all over the world. We think that thanks of this network, this course can arrive to all the honorary consuls and through their embassies arrive at respective ministries of health with the goal to arrive at the end of this informative chain, but we can say also chain of goodness, can arrive this course to the peripheral, to the small centers of health, to doctors, to nurses, to all people that are involved in this epidemia, in this pandemic. We think that this course will be sure efficacy, understandable, and simple. Thank you very much.
Thanks, Guido. Before starting with the lessons, may I thank you, Centro di Salute Globale, for the organization of this training program. May I thank UCOI for the diffusion of this program in all the countries represented from them, and the Consulate of Yemen for the technical assistance, particularly Francesco Orlando. So we can start with the lessons.
Good morning and welcome to our course. The course will provide information on what facilities should be doing to be prepared to respond to a case of an emergency respiratory virus such as the COVID virus, how to identify a case and how to properly implement IPC measures to ensure that there is no further transmission to the healthcare workers, patients or others in the healthcare facility. The course contains 3 modules. The first will deal with the preparedness, readiness and standard infection prevention and control. The second will go into the additional precautions and transmission-based precaution, and the third will go into detail about the COVID virus, so its epidemiology, risk factors, signs and symptoms. We are going to start with this module 1. This is preparedness, readiness and infection prevention control. Preparedness for outbreaks is a part of a larger process known as the principles of emergency management. It begins with the prevention and mitigation. These are strategies that can help a facility prevent and reduce the impact of an emergency. The next step is the preparedness and readiness. These are actions that should take place before an emergency. And once the emergency happens, there is the response. These are activities in reaction to a known or suspected event. After response, we are going to recovery. This is where facilities should evaluate the prevention, mitigation and preparedness efforts and should seek to return back to normal and build back better, meaning they should learn from their emergency response. So, what is preparedness? This is the knowledge, capacities and organizational systems developed by governments, response and recovery organizations. This action will take place before an emergency and increase of facilities' ability to respond when the emergency occurs. This should happen at all levels: national, regional, and at the facility level. And what is readiness? Readiness is the capacities in the systems that should be in place to enable a rapid, effective response in case of a health emergency disaster, and to be ready to aggressively contain the event before further spread. What is infection prevention and control? IPC is a basic requirement for outbreak preparedness and a critical element of readiness. It should be an ongoing activity, and to achieve the highest level of effectiveness in the response to COVID outbreak, IPC measures should be already in place. Inadequate IPC measures may lead to transmission not only to patient but also to staff, visitors, and within the community. Because who is at risk for COVID? Basically everyone. And the benefits of IPC are many. Protecting yourself, protecting your patient, and protecting your family and community. Some of the IPC goals and outbreak preparedness are to reduce transmission of healthcare-associated infections, to enhance the safety of staff, patients, and visitors, to enhance the ability of the organization or the health facility to respond to an outbreak, and to reduce the risk of the healthcare facility from amplifying the outbreak. IPC strategies to prevent or at least limit transmission in healthcare setting include the following: ensuring triage, early recognition, and source control. For example, isolating patients with suspected COVID. Applying standard precaution for all the patient and implementing additional precaution, droplet and contact and airborne precaution for suspected or confirmed case of COVID. So, IPC principles. We have standard precautions that should be used for all the patients and additional precautions to use in selected patients depending on presumed diagnosis. Standard precautions include hand and respiratory hygiene, use of appropriate personal protective equipment, also called PPE, infection safety practices, safe waste management, proper linens and environmental cleaning, and sterilization of patient care equipment. This diagram represents the chain of transmission. An infection occurs when a microorganism enters the body and increases in number and damages tissues in the body. For an infection to spread, all steps in the chain must occur. The key to stopping the spread of infection is to break at least one link within the chain. Hand hygiene. We have evidence to prove that this is the best way to prevent the spread of germs in the healthcare setting and in the community at large. We know that our hands are our main tool for work as healthcare workers, but they are also the key link in the chain of transmissions. Think about this when you are going to touch door handles, medication, your mobile, and touching patients in their environment. Hand hygiene includes either cleansing hands with alcohol-based rub product or with soap and water. Alcohol-based are preferred if hands are not visibly soiled, but wash your hands with the soap and water when your hands are visibly dirty. If you use alcohol-based formulation, you should wash your hand at least 20 to 30 seconds. When you wash your hands with the soap and water, you should wash them for at least for 40 to 60 seconds. If an alcohol-based hand rub and soap are not available, then using chlorinated water 0.05 dilution is an option. But be careful, because frequent use may lead to dermatitis and asthma. WHO promotes the 5 moments of hand hygiene. Moment number 1 is before you entering the patient's environment and touching a patient. You should be doing hand hygiene. This involves either alcohol-based hand rub or water and soaps. Before preparing a clean or aseptic procedure, you should be practicing hand hygiene again, and after bodily fluid exposure or risk, you should be practicing again hand hygiene. This means if you have soiled gloves or soiled hands, you should be taking them off and practicing hand hygiene with water and soap. After touching a patient, you should also be performing hand hygiene, and after leaving the patient environment, you should again be performing hand hygiene. This means that after taking off your PPE, you should be performing hand hygiene as the last step. The second element I'd mentioned earlier was respiratory hygiene. Why respiratory hygiene or cough etiquette is so important in time of outbreak such as COVID or any other respiratory outbreak? Good respiratory hygiene or cough etiquette can reduce the spread of microorganisms or germs that cause respiratory infection. The respiratory hygiene includes turning your head away from other when coughing or sneezing, covering the nose and the mouth with a tissue and discarding that tissue immediately, or if no tissue is available, coughing or sneezing into your elbow. And then hand hygiene. Clean your hands with the soap and water or alcohol-based product. For sure, if you have respiratory symptoms, you should wear a medical mask and stay away from others. No introductory kissing or shaking hands when you are ill. Standard precautions also include the steps to safe injection. So this means you should always have a clean workspace, perform hand hygiene, perform medication preparation with the sterile safety syringes, sterile vial of medication. You should perform skin cleaning and antisepsis and appropriate collection of sharps and appropriate waste management. So, what is decontamination? Decontamination is the process that removes soil and pathogenic organisms from objectives so that they are safe to handle, safe to process, safe to use and to discard. Cleaning refers mainly to the first step required to physically remove contamination by foreign materials. It will also remove organic material such as blood excretions and microorganisms to prepare a medical device for disinfection or sterilization. Disinfecting refers to the process to reduce the number of viable microorganisms to a less harmful level. This process may not inactivate bacterial spores and some viruses, and for this reason sterilization is needed. Sterilization is a validated process used to render an objective free from viable microorganisms, as mentioned above. Cleaning. Cleaning is the physical removal of foreign material and organic material. It physically removes rather than kills microorganisms. It's accomplished with water, detergents, and mechanical action. The basic principle of cleaning and disinfecting apply to all patient care areas. So be sure to always clean the patient care equipment between each use. And where possible, use dedicated cleaning supplies in higher risk areas where there are isolation rooms, for example. The cleaning supplies for isolation should be kept and only used in the isolation room. How to clean? When cleaning, always move from the cleanest area to the dirtiest area and clean from high to low areas, outer to inner. Clean the isolation areas with their own dedicated equipment. Damp dusting and wet mopping is recommended to minimize dust. And the water you should be using should be clean, and spraying of disinfectant is not recommended. For isolation rooms, you should be increasing the frequency of cleaning. Currently, WHO recommends using 70% ethanol alcohol to disinfect small areas between uses, such as reusable dedicated equipment, for example, thermometers. When you use thermometers, then you can disinfect with 70% ethyl alcohol, or sodium hypochlorite at 0.5%. So I'd like to remind you that for hand washing the dilution is 0.05, while for disinfecting the dilution is 0.5%. Safe handling of soiled linen. So how to manage used linen on the wards? For sure you should wear PPE according to the risk when handling used or soiled linen. And you should be handling soiled linen with minimum agitation to avoid contamination to the environment. Place the soiled linen into bags at the point of care. Don't go outside with the soiled linen in your hand. If the linen is grossly soiled, remove the gross soil with the gloved hand and discard the solid material into the toilet. Place the soiled linen into a clearly labeled leak-proof container in the patient care area before transport. If washing machine is not available, you can use this way for washing. So soak linens in hot water and soap in a large drum using a stick to stir and being careful to avoid splashing. After this, you can soak the linens in 0.05 chlorine for 30 minutes, and finally the laundry should be rinsed with clean water and the linens allowed to dry fully in sunlight. The last pillar is the waste management. Here you can see the chain for the waste management, so from minimizing the waste up to disposing. We have reached the end of Module 1. Thank you for listening. You can now continue to Module 2, where we will speak about additional precautions. Thank you. Welcome to this new presentation. During this presentation, we will describe the general principles of IPC when you are caring for a patient with COVID. We have general principles we should apply. First of all, recognize suspect patients early and rapidly and apply appropriate source control. Then we should apply routine IPC, standard precaution, for all patients and apply additional precautions in selected patients depending on the presumed diagnosis. Before going to speak about additional precaution, we should understand the difference between surgical or medical mask and respirator. Surgical mask is a loose-fitting disposable device that creates a physical barrier between the mouth and the nose of the wearer and potential contaminants in the environment. While respirators, and we have different type, N95, FFP2, FFP3, is a respiratory protective device designed to achieve a very close facial fit and very efficient filtration of airborne particles. So a surgical mask blocks large particles of droplets, splashes, sprays, or splatter that may contain germs, like viruses or bacteria, keeping it from reaching your mouth and nose. But by design, a surgical mask doesn't filter or block very small particles in the air that may be transmitted by certain medical procedure. Respirators are tight-fitting masks designed to create a facial seal, and respirators provide good two-way protection by filtering both inflowing and outflow of air. These are designed to protect the wearer, but when they are worn properly. So, as I told you, we have different type of respiration: FFP2, FFP3, N95, N99. They differ each from the others based on different filter capacity. So if we look at FFP2, we can see that the filter capacity is at least 94%. N95, the filter capacity is at least 95%, and N99 and FFP3 is at least 99%. The respiratory type N95 is an American standard, while Europe uses a different standard, and the standard is the filtering phase peace score, FFP. So, in a comparison of respirators, we could approximate, say that N95 is almost equal to FFP2, while N99 is equal to FFP3. Here you can see the right way for wearing a respirator. Always do a seal check after wearing the respirator and before entering in contact with the patient. For a negative pressure seal check, you should inhale deeply, and if there is no leakage, negative pressure will make respirator cling to your face. If there is a leakage, this will result in loss of negative pressure in the respirator due to air entering through gaps in the seal. So PPE, personal protective equipment, are the last line of defense against hazard that cannot otherwise be eliminated or controlled. And an appropriate use of PPE means that they are only effective if used throughout potential exposure periods. They are only effective if the adherence is 100%, must be properly used and maintained, and doesn't eliminate need for hand hygiene. For COVID-19, we must use, in addition to standard precaution, we should use droplet and contact precautions when caring for patient with COVID or suspected patient, and use aerosol precaution during aerosol generating procedure. Aerosol generating procedure, here you can find a list of these procedures, like aspiration of respiratory tract secretions, intubation, cardiopulmonary resuscitation, and so on. So droplet precautions means for the health workers to wear a medical mask or a surgical mask when within 1 meter of a patient. Wear eye protections like goggles or face shield if there is a risk of splashes onto the face, and wear a gown. The droplet precautions for patients are to place the patient in a single room if available, and if it is not available, at least separate from others by 1 meter, and limit the movement out of the hospital room. Contact precautions means use disposable or dedicated patient equipment when possible, and if it's not possible and you have to share the equipment, clean and disinfect between use. It also means avoid contaminating surfaces not involved with direct care of the patient, like light switches, mobile phone, and so on. And ensure appropriate and frequent, at least daily, environmental and equipment cleaning, disinfection, and sterilization, as we discussed during the Module 1. We say that when we are going to do some aerosol generating procedures, we should use aerosol precaution. And aerosol precautions are a respirator in addition to eye protection and gown. So here you can find a summary of the WHO of the WHO recommendation on PPE. So if you are in a triage or points of entry, you should wear a surgical mask. When caring for a suspected or confirmed case of COVID with no aerosol generating procedure, you should wear goggles or a face shield, gown, gloves, and a surgical mask. While if you are caring for a patient or a suspected patient with aerosol generating procedures, you should use gloves, goggles, and gown, and respirator instead of the surgical mask. When you have to transport a suspected or confirmed case of COVID, you should wear goggles, gown gloves, and the surgical mask will be enough. The basic principle of IPC and the standard precaution should be applied in all healthcare facilities, including the outpatient care and the primary care. So, for COVID-19, the following measures should be adopted: triage and early recognition, emphasis on hand hygiene, respiratory hygiene, and remember that medical masks should be used by patients with respiratory symptoms. So every time a patient has the respiratory symptoms, ask him or her to wear a mask. Appropriate use of contact and droplet precautions for all suspected cases, and aerosol precaution if you are going to do some aerosol generating procedure. Prioritization of care of symptomatic patients, and when you receive a symptomatic patient and the patient is required to wait, ensure that he has a separate waiting area. So don't leave the patient together with the other patients. And finally, educate patients and families about the early, and basically the communities, about the early recognition of symptoms, basic precautions to be used, and which health care facility they should go. Okay? We reached the end of our presentation, of the second presentation. Thank you for listening. You can now continue to Module 3, where we will speak about epidemiology, transmission, signs and symptoms of COVID. Thank you. Welcome to the last module, and in this module we will go into details about the novel coronavirus, its epidemiology, transmission, risk factors, and signs and symptoms. We know that there are different types of coronaviruses that cause respiratory and sometimes even gastrointestinal symptoms. Respiratory diseases can range from common cold to pneumonia, and in most people the symptoms tend to be mild. However, we know that some coronaviruses cause severe diseases. This is the case of SARS-CoV coronavirus in 2003 in China, and the MERS coronavirus in Saudi Arabia in 2012. The name of coronavirus comes from the Latin word corona, meaning a crown. Under an electron microscope, the virus looks like it's surrounded by a crown. So that is why we call them coronaviruses. Viruses and the diseases they cause often have a different name. For example, HIV is the virus that causes AIDS. WHO announced COVID-19 as the name of this new disease on 11th February 2020. From a risk communications perspective, using the name SARS can have unintended consequences in terms of creating fear for some populations, especially in Asia, which was affected by SARS in the outbreak on 2003. For that reason, WHO has begun referring to the virus as the virus responsible for COVID or the COVID virus when communicating with the public. We know that coronaviruses circulate in a range of animals. Sometimes these viruses can make a jump from animals to humans. And this jump is called spillover and could be due to a wide range of factors like mutations or increased contact between humans and animals. Animals can sometimes carry harmful germs that can spread to people and cause illness, and these are known as zoonotic diseases. Animals can sometimes appear healthy even when they are carrying germs that can make people sick, depending on the zoonotic disease. And the zoonotic diseases have different modes of transmissions, but usually from the animals that we call reservoirs, the disease goes to human, either directly with the direct transmission or through a secondary host. And we know that the reservoir for SARS is the civet cat. The reservoirs for MERS is the camel, but we don't know the reservoir for COVID virus. What we know is that the virus initially occurred in a group of people with pneumonia who had been associated with the seafood and live animal market in the city of Wuhan, China. And we know that a recent study discovered that SARS-CoV-2, the virus, is most closely related to two bat-derived SARS coronaviruses. So, probably the hypothetical zoonotic transmission for COVID is from that the virus is inside a primary host that probably is a bat, and from the primary host the virus goes to human, maybe through a direct contact or most probably through an intermediate host. Here you can see the epidemic curve from the beginning of the outbreak on 31st December 2019 up to now. And you can see that on 30th of January, WHO declared COVID as a public health emergency of international concern. And the public health emergency of international concern is a decision made by the Director General of WHO on evidence that he collects from other countries and from many different sources about a current infection, whether or not it's unexpected and whether or not it's spreading international, and might require a global effort to stop. The implication for countries are that they must begin to share all data they have about the outbreaks occurring in their countries and any information that they may know about the outbreak. On 11th of March, WHO has declared COVID viruses as a pandemic. WHO definition for pandemic is the worldwide spread of the new disease. Here you can see the situation in Italy update to 3rd of April, with the number of cases, the number of deaths, and among these deaths, it's interesting to note that 9% is among healthcare workers. The median age of cases is 62 years, and the case fatality rate reported is 11.5. That is quite different from the case fatality rate reported in China, that was 2.3. Here you can see the number of deaths, and the mean age of patients dying for coronavirus-19 infection was 78, and you can see the number of comorbidities diagnosed before COVID-19 in the patient. Overall, 2.1 of the sample presented with no comorbidity, while 21.6 with a single comorbidity, 24.9 with 2, and 51.8 with 3 or more. People talk about the new coronavirus being more or less infectious than a normal flu or than SARS. But what does it mean? In this step, we will look at how we measure the infectiousness. The basic case reproduction number, R0, is the measure of the spread. It's the average number of successful transmissions per case when everyone in the population is susceptible. While R0 is above 1, case numbers increases. When R0 is 1, the number of cases is stable, and when R0 is less than 1, number of cases decreases. So it's clearly important to know what is R0 is. For COVID-19, because it's caused by a new virus, SARS-CoV-2, we can assume that everyone is susceptible. We can estimate R0 by looking at the average number of secondary cases per case, or from looking at how cases increase in the population over time, which is known as epidemic curve. Imagine an outbreak where R0 is 2, the first. One person gets a virus and transmits it to 2 people, and each of those people transmits to 2 people. You can see that the number of people infected would increase quite quickly in the population. And if R0 is 3, the number, it means that each person will give rise to 3 new cases, and the outbreak would increase even more quickly. Here you can find some R0 for different diseases, and in this way, looking at this picture, you can understand and compare to other infectious diseases. For COVID, R0 is much lower than for other infections, which are known to transmit particularly easily, like measles or chickenpox, and it's in a similar range to SARS, Ebola, and seasonal influenza. So R0 for COVID is between 2 to 4.5. It means, using the available data, that each case gives rise to between 2 to 4.5 new cases. What we know is that R naught is not fixed. R naught depends on three factors. How long people with the COVID are infectious, the probability of transmission per contact between susceptible and infected individuals, and the average rate of such contacts. How long people with the COVID are infectious and the probability of transmission per contact depends on characteristic of the virus and also of the people infected. So the first two depends on the virus, but the average rate of contact depends on the population. And this varies between populations. Reducing contact is the key for the interventions. So, if interventions are successful in reducing contact, R0 can be decreased. When we speak about reducing contact, we speak about quarantine, isolation, and social distancing. Quarantine separates and restricts the movement of people who are exposed to COVID to see if they become sick. Isolation separates sick people with COVID from people who are not sick. So basically, quarantine is for exposed people and isolation is for sick. When we speak about social distancing, we are speaking about increasing the physical space between people to avoid spreading illness. Social distancing measures are staying at least 1 meter away from other people, working at home, closing schools, don't visit other people, and cancelling conferences and meetings. In epidemiology, the idea of slowing a virus spread so that fewer people need to seek treatment at the same time is known as flattening the curve. It explains why so many countries are implementing social distancing guidelines. The curve refers to the projected number of people who will contract COVID over a period of time. The curve takes on different shapes depending on the virus infection rate. It could be like the green, a steep curve in which the virus spreads exponentially, and the total number of cases increases to its peak within few weeks. Infection curves with a steep rise also have a steep fall, because after the virus infects everyone who can be infected, case numbers begin to drop exponentially. The faster the infection curve rises, the quicker the local healthcare system gets overloaded, sometimes beyond its capacity to treat people. A flatter curve, on the other hand, assumes the same number of people finally get infected, but over a longer period of time. A slower infection rate means a less stressed healthcare system. Incubation period. Incubation period is the time between acquiring an infection and beginning to show symptoms. We know that for COVID virus, the median incubation period is from 5 to 6 days, with a range from 1 up to 14 days. And what we know, thanks to studies in Germany and China, is that transmission of the virus can happen during the incubation period. We also know that asymptomatic infection has been reported from many settings, and there are reports of cases remain asymptomatic through the whole duration of laboratory and clinical monitoring. And we know on top of this, that asymptomatic individuals can be infectious. What is still not clear is how long people remain infectious after recovery. We know that coronaviruses are transmitted, generally, coronaviruses are transmitted via droplets, aerosols, and contact. Droplets are larger particles that travel under 1 meter, while aerosols are smaller particles travel over 1 meter. And coronaviruses are transmitted via contact, for example, with objects that have been infected with droplets and then touching eyes, nose, or mouth. About coronavirus transmission at the present, we know that coronavirus spreads via droplets or via contact, while transmission by aerosol is still under investigation. And we still don't know how long COVID survives on surface, because a recent study found a large variability ranging from 2 hours to 9 days, depending on a number of factors, including the type of surface, temperature, humidity, and so on. But we know that an effective inactivation could be achieved within 1 minute using common disinfectants like 70% ethanol or sodium hypochlorite. If we look at symptoms, we know that we have 3 main symptoms. Fever, almost half of patients are with the fever, dry or productive cough, and sore throat. Others are diarrhea, reported by 2 to 10% of patients, general weakness and pain. Loss of smell and taste are reported also in asymptomatic patient. And we know that patient can be asymptomatic with no symptoms, and symptoms could be mild with a fever and cough or shortness of breath up to severe pneumonia and kidney failure. Hospitalization occurred in 30% and severe illness requiring ICU or intensive care unit or respiratory support accounted for 4%. And as we have already discussed, severe illness is more likely in those who are elderly or who have other health problems, mainly hypertension, diabetes, cardiovascular disease, chronic respiratory disease, and cancer. If we look at the children, we know that they are a very small proportion of the case reported. It's possible that this reflects a lower risk of children to develop COVID, but seems that it's more probably that this indicates that children are as likely to be infected as adults, but they experience mild clinical manifestations. So it seems that it's harder to detect sick children. For pregnant women appear to experience similar clinical manifestation as non-pregnant adult, and there is still limited evidence on severe outcome such as miscarriage, preterm birth, stillbirth, and fetal distress. What we know is that the virus has not been found in breast milk. For the diagnosis is mainly done by a test called PCR, polymerase chain reaction, and this test identifies the virus based on its genetic fingerprint. I'm not going to talk about treatment because at the moment we have no drugs that are known to be effective against COVID. For sure, there are some options that are being looked at in other coronaviruses like SARS and MERS, studies in the laboratories and in animal studies, which give us some idea of drugs to try. But at the moment, there is nothing that has been proven to be safe or effective in humans. So we reached the end of the course, but here you can find a list of useful links to guidelines and recommendations done by the main agency WHO, CDC, London School of Hygiene. The last link is to Istituto Superiore di Sanità if you'd like to stay up to date on the Italian situation. Thank you again, and please stay safe.
Thanks to everyone. As you have seen, everyone is speaking from his house. Of course, this is the strongest and the best way to afford the infection that we are using now here in Italy. This lesson and other materials is available on the website of Centro di Salute Globale. You can see below the address. So thanks to the Centro di Salute Globale, thanks to UCOI, thank you to the Yemen Consulate for the technical assistance, and thanks to the health local authorities of Regione Toscana and of Udine of Regione Friuli for the procedures that you can find on the website. Thanks to everybody, have a nice day, and best to all.